For those of you who have joined us during Dr. Bach's talk and missed the introduction, I'm Dr. Caitlin Dunn. I'm one of the co-directors at PCRM. This is our 8th annual Fertility and Reproductive Medicine Symposium. We usually have between 150 to 250 people here. I can see the attendance this year is excellent, so welcome to everybody. Thank you for coming. The next in our lineup of speakers is Dr. Jason Kong, and he's going to talk to us about preconception and pregnancy considerations for diabetes. Dr. Kong is a clinical associate professor at UBC in the Division of Endocrinology. He did his training at UBC and his endocrine fellowship at New York University. Dr. Kong is currently practicing general endocrinology at VGH and diabetes in pregnancy at BC Women's Hospital. And Dr. Kong did not include this in his bio, but I found out that he was recognized this year with a really prestigious award, the annual Endocrine Fellows Teaching Award. So congratulations, Dr. Kong. And thank you for being here. I'll ask you to go ahead and share your screen.
Okay, so thank you very much, Dr. Dunn. And really is a pleasure to be here. And so let's just see if you can see. Are we okay?
Perfect. Once you hit slideshow, you'll be good to go. Perfect.
Okay. Listen, thank you very much for the opportunity to speak today. And it's a pleasure to speak to everybody. And today I'd like to talk about type 2 diabetes, preconception, and early pregnancy considerations. So first, in terms of land acknowledgement, I would like to acknowledge that I'm coming to you from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And in regards to financial disclosures, I have no interest to disclose. So over the next 20 minutes or so, what I'd like to talk about in terms of overview is type 2 diabetes, a bit of background. And then in regards to our Diabetes Canada preconception guidelines. Now of note that these guidelines were last updated in 2018, but will be updated hopefully within the next year. I'll talk about it in regards to glycemic targets, those to minimize early complications such as miscarriage or major congenital malformations. And then I want to briefly talk about a couple of hot topics, which one is GLP-1 agonists and 2, inositol. So first, in regards to type 2 diabetes diagnosis, so we diagnose type 2 diabetes with a hemoglobin A1C 6.5% or higher, or specific glucose data. For example, a fasting plasma glucose of 7.0 or higher, or a 2-hour glucose post-75 gram test of 11.1 or higher, or a random glucose 1.1 or higher. And of note, if patients don't have any symptoms of hyperglycemia, these tests should be repeated for confirmation. Now, thinking back to medical school, so we all know the Starling curve of the heart. But being an endocrinologist, but this is a Starling curve of the pancreas. And what it's supposed to illustrate here on the x-axis is increasing insulin resistance. And as you get increased insulin resistance, we're able to maintain relatively normal glucose levels because we can just compensate by making increasing amounts of insulin. But all of us have a limit in terms of the amount of insulin that we can make. And once that threshold is reached with increasing insulin resistance, glucose begins to rise abnormally. And that pathophysiologically, we have a line here, which we would call diabetes, in this case, type 2 diabetes. Now, in regards to just general complications of diabetes, we split up the complications, of course, into the macrovascular complications and the microvascular complications. And here, unfortunately, the most common cause of death in those with diabetes type 2 is cardiovascular disease, or MI. The other macrovascular complication, stroke and peripheral vascular disease. And then, of course, we split the other complication into microvascular complications and nephropathy. In regards to kidney disease, unfortunately, diabetic kidney disease is the most common cause of dialysis in the Western world. We have retinopathy, and retinopathy is split into background retinopathy, which is essentially non-vision threatening, and proliferative retinopathy, which we do consider vision threatening. And therefore, we recommend people with diabetes should always get routine, regular eye exams to screen for retinopathy. What I've got here is just an illustration here. So in the center here is a normal fundus, and just here in the two other panels, just to show neovascularization, which is essentially new fragile blood vessels, which have a propensity to burst and hemorrhage, which then leads to visual impairment. And of course, the last microvascular complication is neuropathy. And we split neuropathy in regards to autonomic neuropathy and peripheral neuropathy. Now, what about specifically in regards to the talk today, which is in regards to type 2 diabetes and pre-pregnancy and early pregnancy considerations? What this is, I found, is the largest cohort study trying to look at those with type 2 diabetes and outcomes in regards to fertility. For example, chances of birth, infertility, and miscarriage. And what this was is a large database cohort study in Sweden, in which over the course of 20 years, they identified those with type 2 diabetes in this population and those without type 2 diabetes in population between the age of roughly 18 and 45. And what they also did is they also coded the issue of pregnancy, infertility, and miscarriage, in other words, fertility outcomes. And those with diabetes type 2 compared without type 2 diabetes, unfortunately, the chances of birth they found in regards to less chances of birth with type 2 diabetes with an adjusted odds ratio of 0.73. Or for example, looking at miscarriage, type 2 diabetes versus no type 2 diabetes, they had a greater chance of miscarriage with an adjusted risk ratio overall of 1.78. And most of these outcomes, unfortunately, were not favorable for those with type 2 diabetes. What this is specifically a study looking at those with type 2 diabetes and the use of reproductive assisted technologies. And unfortunately, there really is a paucity of data looking at this. But what this is a recent examination a year ago. This was at a single center fertility clinic in which they took a consecutive series of those without type 2 diabetes compared to with type 2 diabetes. In the group, approximately 50 people with diabetes compared to roughly 210 people without diabetes. And they specifically looked at the clinical pregnancy rate, the live birth rate, and the abortion rate, and comparing type 2 diabetes versus non-type 2 diabetes. Unfortunately, there are less rates of clinical pregnancy with an adjusted odds ratio of 0.58. And in regards to live birth rate, type 2 diabetes compared to non-type 2 diabetes, unfortunately, a lower rate of live birth rate as well, with the live birth rate of risk odds ratio of 0.227. And in regards to abortion rate, type 2 diabetes compared to those without type 2 diabetes, unfortunately, an increased rate of that with an adjusted odds ratio of 3.316. So just in general terms, type 2 diabetes treatment. So whenever I talk about type 2 diabetes treatment generically, I would talk about the big three, which is diet, activity, and pharmacotherapy. And in regards to the pharmacotherapy, in regards to dietary therapy, it's very similar to the last discussion we had, where it's essentially we're talking about the Canada Food Guide, having a discrete breakfast and a lunch and a dinner, and generally having fresh food that's well balanced with your vegetables and lean meats and fish and so on, and being very careful in regards to simple carbohydrates, obviously, and sweet food. And the people often ask me in terms of activity, what kind of activity? Frankly, I don't care what kind of activity it is, so long as regular activity done a number of times a week. That helps ensure that this activity continues. And in terms of general pharmacotherapy, gosh, when I started practice, we had basically metformin and a sulfonylurea glyburide and insulin. But nowadays, we have a whole host of new classes of medications to help us control for type 2 diabetes generically. I don't mean in regards to pregnancy, but in regards to just general use. So we have sulfonylureas, glitinides, metformin, a number of various agents that we have. And then we also have more recently in the last few years, which I'm sure everyone's heard about, is these new GLP-1 based therapies, the semaglutide or Ozempics, or the tirzepatides or Mounjaro. And we have a whole host of new medications now to help us control pharmacotherapy-wise in regards to type 2 diabetes. But for the scope of this talk, most of these agents, of course, you cannot use. So, and of course, our old friend insulin, in which case I've got an illustration here of a basal insulin, which you take once a day, which helps control sugar readings in between meals. And then, of course, a dose of prandial insulin or Lispro before breakfast, before lunch, and before dinner to prevent postprandial hyperglycemia. So that's now reflect in terms of our national guidelines, our Diabetes Canada recommendations in regards to type 2 diabetes for conception. So recommendation, for those women of reproductive age with diabetes type 1 or type 2, should receive ongoing counseling in regards to reliable birth control, the importance of glycemic control prior to pregnancy, the impact of BMI on pregnancy outcomes, and the need for folic acid, and to stop potentially embryopathic medications prior to pregnancy. Recommendation, those women with type 2 diabetes with irregular menses or PCOS who lose significant weight or started on potential sensitizers such as metformin or thiazolidinediones, what we call TZDs, don't use so much in them anymore, but we still sometimes do, should be advised that fertility may improve and be counseled regarding possible pregnancy and receive preconception counseling. Recommendation, in regard to preconception care, strive for preconception A1C less than 7%, or preferably, if possible, less than 6.5% if safely can be achieved, to decrease the risk of such things as spontaneous loss, congenital anomalies, preeclampsia, worsening of pre-existing complications, and stillbirth. Recommendation, in regards to preconception care, supplement their diet with multivitamins containing 1 milligram of folic acid at least 3 months preconception and continuing throughout organogenesis. Recommendation, discontinue medications that are potentially embryopathic, and typically those with type 2 diabetes, commonly they're on ACE inhibitors or ARBs for their blood pressure or their nephropathy, and very commonly, they're on their statin to help control their hypercholesterolemia. These medications are teratogenic. Recommendation for preconception care. Women on metformin and their glyburide preconception may continue these agents if glycemic control is adequate until pregnancy is achieved. And this, I must admit, is a national suggestion and is somewhat center dependent and really is reasonable depending upon the local area that you're working in. Women on other anti-hyperglycemic agents should switch to insulin prior to conception, as there's no safety data for the use of these other agents, essentially all the newer agents that we have that I listed before for type 2 diabetes. Recommendation. This is basically says that the women should undergo an eye exam by a visual specialist to screen for retinopathy pre-pregnancy and in the first trimester, and essentially up to the discretion of that professional, subsequent eye examinations thereafter. Recommendation. Those with albuminuria, which is a marker for diabetic nephropathy, should be closely followed for the development of hypertension and preeclampsia. And recommendation. Those with pre-existing diabetes should start enteric-coated aspirin 81 milligrams a day, roughly between 12 to 16 weeks, to try to reduce the risk of preeclampsia. So, in terms of the checklist, use reliable birth control until adequate glycemic control. Attain a preconception A1C of less than 7%, less than 6.5% if possible, even lower if you can in a safe manner. May remain on metformin and glyburide until pregnancy, otherwise switch to insulin. Assess for and manage diabetes complications, that is, get the eye exams and screen for nephropathy with the urinalysis or urinary microalbumin. Folic acid, 1 milligram a day, 3 months preconception, up and through 12 weeks post-conception. And of course, discontinue those potentially teratogenic agents, and typically you're talking about ACE inhibitors, ARB for the nephropathy, and their statin therapy for their hypercholesterolemia. So let's talk a bit about in terms of glycemic targets that we aim for. So this is from our national guidelines, and essentially individual glucose readings try to aim for a fast, preprandial glucose of less than 5.3. Some clinics and diabetes clinics use a 1 hour post. Others use specifically 2 hour post, but either aiming for 7.8 1 hour post or 2 hour post 6.7. And just beware, all these recommendations are made by consensus. Aim for a hemoglobin A1C of less than 6.5%, even lower if possible, to try to reduce the rate of late stillbirth and infant death. And of course, individualized targets in those with problems with hypoglycemia. So what this is the most comprehensive data that we have in terms of cohort studies looking at hemoglobin A1C and the risk of congenital malformation. And essentially what it shows here is with a high A1C of more than essentially 14%, there's an approximate 20% risk of congenital malformation. But as that periconceptual A1C drops and drops and drops, once you get below 7 and even below 6.5, the absolute risk of congenital malformation begins to approach that of the general population. And that's where that number comes from in terms of trying to achieve target A1C. What, of course, is more difficult is trying to find glycemic thresholds for various outcomes. And truthfully, it's very hard to find. But what I did find is a study. And what this was is a cohort study out of China, which looked at a database of 6.4 million individuals who were seen in an area of China. And then they had various examinations, pre-pregnancy examination, first trimester pregnancy examination, and post-pregnancy examination. And what they tried to correlate specifically was the pre-pregnancy fasting glucose level and try to correlate fasting glucose levels with various outcomes. And in this particular slide here, what I've highlighted here is the fasting glucose 5, less than 5, which is essentially normal, 5 to 6, 6 to 7, and so on to greater than 10. And what this is supposed to show here is the spontaneous abortion relative risk, where normal is right at 1, and that risk, although relatively low, begins to rise at a glucose somewhere between fasting glucose of between 5 and 6. I know it's not fantastic data, but truthfully, looking at specific thresholds for various outcomes, truthfully, it's very hard to find. And that's where a lot of suggestions, frankly, comes from consensus. But I think this does kind of correlate with the national guidelines, which suggests try to get a fasting glucose, 5.3 or lower. So let's switch gears a bit, some hot topics. So what's hot in the press now is Ozempic babies, where there's been anecdotal evidence that the use of Ozempic seems to increase fertility. Frankly, in terms of randomized controlled trials, we don't have any yet, but there has been this anecdotal and cohort studies looking at that with weight loss, people seem to have greater fertility. So what are these agents? So what this is the Gila monster. And the agents are GLP-1 agonists. Now we have semaglutide, Ozempic, and tirzepatide, Mounjaro, 2 common ones now. But these agents have really been around for more than 20 years. And the first GLP-1 agonist was exenatide, which essentially is a derivative of the poison of the Gila monster. And what they found was this exenatide did have certain properties to enhance natural insulin production. And that sort of led to thinking that these agents may be useful for diabetes. So essentially, these agents that we have, so there's semaglutide, which is known as Ozempic. There's dulaglutide, known as Trulicity. There's tirzepatide, which is now known as Mounjaro. These are the once-a-week GLP-1 agonists, which are commonly used today. Many years ago, we had the once-a-day liraglutide, which is Victoza, and the twice-a-day exenatide, which comes from the Gila monster. The brand name is Byetta, that aren't so much used anymore. But what we know definitely is what these agents do is that they enhance insulin secretion. And that was the main reason why these agents were used initially. But then it was found, how come these patients on these agents seem to be less hungry and they're losing weight? And it soon began to appear that these GLP-1 agonists have direct effects on the vagal nerve, to slow gastric emptying. So essentially, if the stomach is not emptying food quickly, people cannot physically eat as much because the food fills up in the stomach quite quickly. Not only is there that vagal nerve sort of pathway, we do know that there are GLP-1 receptors in the satiety centers in the hypothalamus, and there appears to be direct stimulation of that. And through these two mechanisms, you get appetite suppression and weight loss. And with this appetite suppression weight loss seen in type 2 diabetes, as we all know now, is that there have been studies looking in the non-diabetes population, and they're quite popular in the general population for general weight loss. But the balance of these things lead to decreased fatty liver and decreased markers for insulin resistance with decreased adipose tissue. So generically, insulin resistance. So we think insulin resistance is inadequate glucose response to insulin, either the insulin we make endogenously or exogenously administered, those with type 2 diabetes. Okay. Insulin resistance is most commonly associated with obesity. And it's associated with visceral fat, not subcutaneous fat. There was an elegant study in the New England Journal of Medicine in the early 2000s where a plastic surgeon thought, maybe we could treat insulin resistance by simple liposuction. Okay. And in a series of these patients with liposuction, they found that unfortunately, markers of insulin resistance were unchanged. And it's because insulin resistance is associated not with subcutaneous fat, but visceral fat, and in particular, intrahepatic and intramyocyte fat accumulation. Okay. This disordered deposition of fat leads to reduction in adiponectin. And we know that adipocytes are an endocrine gland. They secrete many different hormones, some of which was adiponectin, which has an anti-inflammatory property. Okay. And thus, we think that the low adiponectin is associated with pro-inflammatory cytokines, which are then unfortunately is associated with insulin resistance. So it is thought that if we can find some way to decrease visceral fat, that we will be able to decrease the amount of fat and then hopefully increase the amount of adiponectin and sort of tip the balance in terms of pro-inflammatory cytokines versus anti-inflammatory cytokines and help reverse insulin resistance. So this is the STEP trial. So this is the landmark randomized controlled trial of using semaglutide, which is known as Ozempic or Wegovy, specifically for weight loss. And truthfully, we've not seen these kind of any medication help with weight loss to this kind of extent. This was published a few years ago in New England Journal of Medicine. And what this is supposed to show is essentially that versus placebo over approximately 68 weeks, that the use of semaglutide at 2.4 milligrams a day, which is sort of the full weight loss dose, is that there's a mean 15% change of weight from baseline. And here on the right panel is to show what percentage of those on treatment with semaglutide reach more than 5% of their body weight loss versus 10% versus 15% versus more than 20% of their body weight loss versus placebo. And these kind of numbers, 86, 69, and 50, and 32, we've not seen those kind of dramatic numbers with any pharmacotherapy for weight loss before. And they also mentioned it in this landmark trial too, that approximately 40% of the people in the trial had borderline type 2 diabetes or pre-diabetes. And we found that by the end of the trial, that a large proportion of those on semaglutide had reverted from pre-diabetes back to normal glycemia. This is the SURMOUNT trial, which is the landmark trial of tirzepatide or Mounjaro. And this to show similarly too, that with the various doses of this medication, that there's significant body weight loss. And in, for example, in this particular trial, that on the full effective dose, that almost 60% of individuals had lost more than 20% of their body weight, okay, which has not been seen, frankly, with any other pharmacotherapy in the past. And in this particular group, again, roughly 40% of those entered into the trial, because it was a weight loss trial, not a diabetes trial, but 40% had borderline diabetes, and a large percent of them had reverted to normal glycemia. So the last thing I want to talk about is inositol. And And what this is a depiction of the intracellular action of insulin. And what it's supposed to show you, if you've got the cell, you have the insulin receptor, and you have the insulin stimulating the insulin receptor, which then stimulates IRS, pyruvate kinase, and the cascade of intracellular enzymes. The end result is translocation of GLUT4, which then leads to intracellular movement of glucose or lowering of glucose, and increase of glycogen synthesis. Okay, and we know that inositol can act as a second messenger to potentiate this cascade. So inositol is essentially found and made by the liver and the kidney. It also found in foodstuffs, primarily fruit, nuts, and some vegetables. In any case, inositol phosphoglycan sits in the cell wall, and when insulin is stimulated, the inositol becomes intracellular and helps potentiate this cascade. In other words, acts almost as an insulin sensitizer. Inositol. So essentially, there are 9 stereoisomers. Myoinositol by far is the most abundant of this isoform. The second most abundant form is D-chiroinositol, which is essentially made from converting myoinositol to D-chiroinositol under facilitation of insulin. It needs insulin. In any case, so myoinositol is from dietary intake. It helps potentiate translocation of GLUT4 to the cell surface, and therefore intracellular influx of glucose. It is also associated with reduction of free fatty acids from adipocytes, and it appears that it may enhance FSH-mediated pathways, which regulate proliferation and maturation of granulosa cells. And I mentioned too, so DCR or D-chiroinositol is the second most abundant formulation of inositol, and it also helps facilitate insulin in regards to translocation of GLUT4 and movement of glucose into the cell, and also enhances production of glycogen. Now, one negative thing, it appears that maybe high levels of D-chiroinositol in the ovary may actually increase the level of androgen, and we think via the inhibition of aromatase. So again, inositol. The normal ratio of inositol, myoinositol to D-chiroinositol is approximately 40:1. Now, with increase in insulin resistance, as I mentioned before, that the conversion of MI to DCI is under the assistance of insulin. So you have increase in insulin levels can lead to increased conversion of myoinositol to D-chiroinositol. And therefore, if you look at, for example, in ovaries, in the non-PCOS ovary, the ratio of MI to DCI is 100:1, versus in those with PCOS, there's a greatly reduction in the level of myoinositol. Okay, as I mentioned before, that very high levels of DCI intra-ovary can lead to increased androgen. In the last few minutes, is there evidence for use of inositol for type 2 diabetes? And truthfully, it's messy. Why is it messy? It's because there's a lot of very small randomized trials, and it's very difficult to interpret. Okay, this is a meta-analysis published a few years ago which tried to answer this question. And essentially what they showed is, yes, that the myoinositol may have mild effects in terms of lowering plasma glucose, lowering 2-hour glucose after glucose load, and perhaps a reduction in abnormal glucose tolerance. No effects on A1C. They have some mild effects in fasting insulin, but essentially mild effects. What about using inositol for polycystic ovarian syndrome? Gosh, unfortunately, it's quite messy as well. And the reason there's been a lot of small randomized controlled trials, and there's been attempts to do meta-analyses, but the problem, frankly, with meta-analyses is that if you got multiple small trials with all different weights, it's very hard to have a good meta-analysis. In any case, the most recent meta-analysis done this year in the JC&M tried to take a look and answer this question, and unfortunately, they came to the conclusion evidence supporting use of inositol for the management of PCOS is limited and inconclusive. Some evidence suggests potential benefits of myoinositol or D-chiroinositol for certain metabolic measures and potentially DCI for ovulation, although I disagree with that. And it's because DCI can lead to increased androgen. And looking at these two small trials, one trial was of 20 participants in 1999, And the second trial was 44 participants in early 2000s. But in any case, in other instances, inositol may have no effect on other outcomes. So in terms of conclusions, so preconception, I am in favor of helping to reduce insulin resistance by reducing BMI. And I actually am a big proponent of using GLP-1 agonists for helping diabetes and decreasing insulin resistance. Although I will concede, to date, there is not a good randomized controlled trial of using these agents for PCOS specifically, but there's lots of good evidence helping reduce insulin resistance. Okay. In regards to inositol, I think inositol for glycemic control, there's lots of other agents that are quite helpful, and I'm not sure if it's benefit at all. In regards to inositol use for treatment of PCOS, I think, frankly, there's little harm to use, to try, but I'm not sure if it really has much benefit. But if you're going to try, that I would use myo-inositol, and the dosage range is 2 grams to 4 grams in a day. Thank you very much. And I apologize to my colleagues who are maybe not from BC, but being here in Vancouver today, the Vancouver Canucks are starting the regular season tonight.
All right, thank you very much, Dr. Kong. We do have a minute here to address some questions. So let's jump into the Q&A box. Is continuing metformin while pregnant okay? What are your thoughts?
The answer is specific sentences, yes. So insulin is the drug of choice which we like to use, but there can be advantages. If I see someone with a large BMI, it has been shown to help reduce excessive weight gain in those who have a very high BMI, because we can't use agents like GLP-1 agonists in pregnancy. So I think it's advantageous for those who have a large BMI. In those centers where there's no access to insulin, I would definitely use metformin if you can't use insulin.
Okay. And just quickly, are there any negative effects of using inositol?
No, I don't think it has any serious side effect. It's cheap. The question is it effective? Only high-dose D-inositol may actually increase antigens and worsen the PCOS. So, but myo-inositol, no problem at all. The question is, does it have any efficacy?
Excellent, thank you. Now, just in order to stay on time, I can see 3 more questions popped into the chat, which sound really interesting. If you don't mind hanging around and just answering those by typing into the chat, that would be
No problem.
really helpful. And then we can move on to our next speaker, which happens to be me.
Thank you.
Thank you, Dr. Khan.